your doctorate?
Yes. Yeah.
Okay, congratulations.
Yeah. Shout it out for me. Thank you.
Yes, Dr. Alan Hyde.
Yeah. As of yesterday.
Yes, yes.
Yeah, it was exciting. Almost cried.
Yeah.
Legitimately.
It's a lot of hard work.
Thank you.
You deserve it. Yeah.
Yeah, I
Congrats.
appreciate that.
Yeah.
Thanks for shouting it out.
You're welcome.
I would have never done it. Maybe I should.
You should. I'll do it for you.
So family nurse practitioning.
Yes.
Let's talk about it.
Okay.
I titled the show tonight, Understanding the Difference Between Narcotics and Prescribed Medications. I know we kind of talked a little bit about that. We'll talk about many other things when we were talking about the show before,
Yeah.
but maybe we can start there and just kind of talk about what you do, why you prescribe. You work at the VA, and what you're helping people out with over there at the VA.
Yeah, so as a family nurse practitioner, I function as a medical provider, prescribing, diagnosing, assessing, coming up with treatment plans for veterans at the VA. I've been there for 13 years. I've been working with the homeless veterans for almost 5 years now. And in that realm, it's an interesting program because my role as a family nurse practitioner varies a little from a psychiatric nurse practitioner, which provides the mental health for veterans, and I do a holistic approach with their medical care. So treating hypertension, treating diabetes, anything in the body essentially for all of our veterans that come through the homeless program. And in the homeless program, a lot of people don't know about us. We often hear, well, I didn't know that they existed. Obviously, you have to be a veteran, enrolled in the VA care, eligible and enrolled in veterans health care. And in our program, you really need complex help with case management. So you're not able to function in just a shelter alone. You need housing, employment, help with finances, help with mental health, depression, bipolar, schizophrenia. We treat all those conditions, or you have a substance abuse addiction that you're maintaining sobriety. So like sober living, essentially there's an accountability piece with urine drug screens, breathalyzers, but also it's a structured environment that provides more of that case management if you need help with the employment pieces, the housing. So
yeah. You mentioned something important too, maybe for like, let's say a family member has someone who is a veteran. Is there anything they could do to help them kind of initiate that process? Not, I mean, we don't want to facilitate anyone doing anything for another adult, but to help kind of get that process going to qualify for VA services?
In the VA, and I don't particularly know all the ins and outs, but if you are a veteran and you need health care or you want to see if you're eligible, you can go to a VA facility or the va.gov website and see if you're eligible. There's numbers to call as well to get enrolled. So that is a first step to become eligible for the homeless program. Would be you have to be enrolled in the Dallas VA. And if you're coming from another VA, because we do get veterans that come from, say, Houston, Central Texas, out of state, you are enrolled in veteran health care and eligible for services.
Yeah, yeah. And you were saying you work with a wide range of issues as to why they would be knocking on your door. But I know in our discussions, oftentimes we discuss kind of the consultations and conversations behind individuals who are struggling with addictions and those kind of things. And I imagine your door's getting knocked on a lot for that kind of stuff. And I liked the point when we were talking about earlier of kind of normalizing medications versus like, well, you're willing to put these narcotics in your body, but then you won't take like a mental health medication.
Sure.
And that's kind of where, as far as me in my lane, that's where my understanding stops and yours begins. And I thought it would be really wonderful to provide our listeners with just kind of some of your knowledge on what are the main differences? Maybe we can start there between like narcotics and a prescribed medication.
So I'll first say I don't really like prescribing narcotics. Nurse practitioners, at least, typically can only prescribe certain narcotics. More dangerous habit forming, you have to be a physician. And really, opiates in general, the indications would be an acute pain, a post-operative pain, but chronic pain is typically not a reason that you want to be on narcotics, because they are habit forming. And I do a lot of work with the opiate crisis as far as educating veterans, educating providers, because we talked about this in the 90s, pharmaceutical companies shared that opiates were safe and that they were non-habit forming, and they were encouraging providers to prescribe. And then as patients got on opiates and their tolerances increase and they need more and they need more and the doses go up and the frequency they need medication goes up and the side effects come in, we discovered that they are habit forming. And then there was a big push to back off opiates, use other pain management techniques, whether that's non-pharmaceuticals, other medications that have benefits on pain but aren't habit forming in the way that an opiate is, and back off because we have the opiate crisis going on. Fentanyl is a huge problem. Many substances have opiates in them, whether the user realizes it or not. And so you can get exposed to opiates on the street, and by street drugs, you can also get them legally prescribed to you. And so one of the things that I do is a lot of education on naloxone or Narcan, and it's a opiate reversal agent that essentially, if someone is overdosing, reverses the overdose. And so when someone is unconscious or passed out or having respiratory distress due to a opiate, whether that's heroin, prescribed opiates, so your hydrocodones, oxycodones, those kind of things, it will reverse that, and so you can save a life. And just kind of circling back to why I do prescribe and when I don't prescribe, in the VA, I typically stay away from it. Studies have shown that opiates, they don't really have much more benefit in a lot of your more chronic pain instances than, say, a lot of the other modalities like ibuprofens, Tylenols, doing interventions like injectables with pain management. So looking at those kind of things, TENS units, physical therapy, nutrition, just so many avenues that you can go down that aren't opiate related, and kind of keeping an open mind to that. Yeah. It's a difficult thing to treat.
Yeah.
Yeah.
Well, it makes me think of the conversation we had about kind of moments in gray areas with clients with chronic pain. It's like here you have someone in chronic pain and they've been in pain for a long time, and how do you sell them on, long-term recovery as a result, when they're just in pain, and there's a lot of gray area in that. But, some of these recommendations that you're touching on too is like there are alternatives, and the biggest part I would say, like with recovery, is that, you really shouldn't have to be sold on it or it's not going to stick. And, it's got to be a willingness to work on some of these things and take the recommendations from the professionals.
We have a hard time treating, not only because the chronic pain is affecting and using opiates, the brain's ability to recognize that that can be a form of an addiction and that they may or may not want to come off it, but we've kind of created this monster where we're feeding it. And, like I said, I really try to not do that. Some instances where I do would be, you know, like an acute back strain. Someone gets injured while they're under my care, and I know it's going to be short term. So they may get something very low dose for just the shortest amount of time. And if it persists beyond that, then I start looking at other things and getting specialists involved. Or some of our veterans, they've been homeless. They get all their teeth pulled, every single one, and so they're in a lot of pain. And I'll do something short term for that as well, so that they can feel comfortable eating and doing their daily activities. But we have a lot of guys that are in recovery, and they'll go through things like that, and they say, I don't want anything at all, because they know that they're more prone to using and abusing and misusing those things. So
Yeah, meth will do that to you, huh?
yeah.
Yeah. That's a huge one in the homeless population, methamphetamines. Yeah. Outside of just like, I would say it's like meth, opiates, things like this, right? Obviously, for the addiction side, we're going to do, you know, the mental health treatments and get them into treatment and those kind of things. But when someone kind of comes into you early, seeking stabilization, are there like standard approaches that you take when they've come in, they've been abusing meth for a long time, and things that maybe a clinician like a therapist wouldn't think about, that we need to know about?
Yeah, and I am not addiction medicine per se. I have been exposed a lot to these realms because of where I work. And often when they come in our program, they need to be stabilized so they're not going through active withdrawal. So usually they do a substance use program first. So whether that was a 28-day or some of the longer term ones, and then they come to us when they are stable. Because if you don't have your mental health condition or your addiction under control, you know, you're essentially stabilized. You're not going through withdrawal. You've developed some coping skills, or you've gotten your medication kind of leveled out so that you're not hallucinating, or your depression isn't so severe that you can't get out of bed, bathe, or go on a job interview, or get up and eat. Once they've kind of stabilized in those realms, then they come to us so that they can start working on their employment, housing, and start moving forward with their lives, working on goals. But when they come see me, and meth especially, we don't get them typically just coming off meth, although we have had veterans who are go get it and then come back to the unit, because we do have relapses that occur. And a lot of what we do in the acute phases would be just my role would be monitoring their cardiovascular health, their blood pressure, their heart rate, making sure that they're not, like alcohol, those kind of things, going into an acute withdrawal. So we're monitoring for the vital signs, right? Blood pressures, all these things, so that we aren't having seizures or DTs, things that can be really dangerous for someone who's in a withdrawal situation. Typically with the, you know, crack, methamphetamines, those kind of things, we don't see as much. Now, if it's really hardcore, we will send them to the ER. But we do more so see serious withdrawal with, say, alcohol or opiates, benzos. Those can be really dangerous, benzodiazepines like your Xanax and whatnot. So we really keep a close eye on those people if they're abusing or withdrawing, for sure.
Yeah. I was trying not to smile when you were talking about they go out and come back with it. It's like when you're working, you know, especially with the homeless population, they're like toddlers, you know, and some of it's kind of funny. You know, I remember when I used to work at the Salvation Army, I would just like the one thing we kept telling you not to do, and you just had to touch the hot stove.
We get the funniest stories, and I won't get too anecdotal, but, I just found it in the parking lot, you know, and you're like, you just picked up this and used it. You don't even know what's in it. You know, it's just, you're like, huh? So your meter to kind of see through the denial and the ruse of how they get it, it gets pretty good when
Yeah.
you're counseling people. And it's been really a huge learning journey for me to get involved in the homeless population, because it wasn't something that I had much exposure to when I was doing training or even working in family practice as a primary care provider. But the homeless veterans, it's just such a blessing to work there because you see them come in, and there's a lot of brokenness in those early days where they're feeling shame or they're just feeling more overwhelmed at this intake process. We've had veterans living in storage units, living in their cars, living on the streets, and they come in and you get to see them grow and develop these coping skills and get to feeling better on medication, their antidepressants, their blood pressure medication, their diabetes. These are the things that I get to really tune up while they're there, and they feel better, they look better, and they're able to meet their goals with work and getting housing. So it's a really a great thing to watch from start to finish when you see them leave.
And up to how long can they be there?
It really depends. We're kind of at the mercy of other departments and entities like the government housing units. You know, there's application processes, and some of the homeless, a lot of people, they don't have birth certificates, documents, identification, things that you need to keep up with in general, you know, and so they have to obtain those things and keep working towards their goals in order to get housing or income or job, you know. So typically 4 months, sometimes longer, sometimes shorter. It just depends on what we're working with. As a medical provider, I diagnose a lot of undiagnosed conditions. And so one of the things we see a lot of will be prostate cancer, and they're very far gone in it because they've neglected their medical care for decades. Prostate cancer is one of the cancers that's very slow growing, and if caught early has a great survival and life expectancy. But if you don't go to the doctor, if you're not getting your routine screenings, if you're not getting your medical care, it can evolve and metastasize. And so there's many veterans that are pretty significantly evolved with their medical conditions, their cancers, whatever that may be. And we're telling people they do have cancer, and then now they need treatment while they're in our care. So we're there to kind of treat it all.
Yeah.
And not only their mental health and their substance abuse, but their whole medical. So.
Yeah. Total recovery.
Yeah.
And that's, you know, anybody I've had discussions with on this show, and you've seen a lot of the episodes, it's that's the objective. We take care of our mental health, we take care of our physical health so that we can stay on top of these things. I was sitting here thinking, it's like I could only imagine how difficult of a process it is to try to get the government to give you your birth certificate. I imagine that's insane.
I don't think it's that hard, actually.
No?
You know?
Okay.
Yeah.
All right. Bless my heart.
Yeah, you can go down to the county courthouse. I think they can print it.
I'm just cynical then, I guess. But yeah, it's you know, like you were saying, staying on top of these things, that and getting to see that from the point where it's just completely been denied and they just let go of it all.
Yeah.
To watch people come back from that too. Really, I think at any level of support that people seek, watching people get on top of the things they're struggling with and keep maintenance of is just a beautiful process to be a part of.
Yeah, and I think it's important to remember too that, like, in your hierarchy of needs, you know, if someone is only functioning with, okay, I need food, I need safety and shelter, they're not really able to say, like, yeah, I can afford my medication, or yeah, I'm going to make this medical appointment, when their basics are not being met. And so when they come in our program, they are able to feel that they have a safe place to stay, that they have food, that they can eat, right? That they're able to then open their mind and open their recovery. And we call it recovery too, from homelessness,
Yeah.
where they can then start thinking of those higher level needs, you know, in the Maslow's hierarchy, is then sort of looking at the joy in their life and looking at what will bring them more quality of life.
Yeah.
Yeah.
Yeah. Well, there's a structure that, or a theory that hasn't changed very much over the years, but it, I think, is a good segue into a theory that has changed over the years that you were touching on.
Okay.
Is the conception, right, that doctors and other individuals would talk about, of like the certain benefits of utilizing certain substances, when we know not even just theoretically anymore, with the evidence that, like, alcohol use.
Yeah.
Remember all the when the nicotine companies, the tobacco companies, bought into all the marketing around, like, this isn't bad for you.
Right.
It's like awful,
Yeah.
right? But I'd love to hear more from the medical perspective of just like, what should people know about their alcohol consumption? Because that's a big one where, it's a Friday night, so, there's a lot of people out there doing it right now. And what do people need to know about alcohol consumption?
Yeah. So, culture and marketing and all these things that tell us something is okay, or even as providers, research and science evolves. When I was younger in my training, there was talk that 1 glass of red wine per night can lower your cholesterol and blood pressure, and encouraging our patients to like, oh yeah, that's fine for your good cholesterol levels, and that'll help your blood pressure. Well, now this is a more recent development within the last 10 years, 5 years even maybe, where we're saying no alcohol level is recommended as a safe level. Harm reduction is 0 drinks, and that would prohibit injuries. That would help with your cardiovascular health, any cancers, liver, all these things that we know alcohol in general is directly related to increased risks for colon cancer and other gastrointestinal things, liver included. And so if you want to ask your provider, which I always encourage having a discussion with your provider, because what culture says and what social media says, and even driving down the highway and the billboards, I just think it's so amazing and kind of crazy that you can buy beer at Chuck E. Cheese. I've seen that. Movie theaters, anywhere now serves alcohol. And so to me, that says as a culture that it's a very acceptable thing. Mom wine hour or whatever that is. Now, I'm not saying it's bad. I'm just saying I think the message is mixed in that it's safe, it's okay, we all engage in this, but medically, and that's what I'll just stick to, we say no alcohol is considered safe or healthy, I should say. But if you are going to drink, there are still kind of these recommendations that, like, maybe no more than 1 for females and 2 for males, 7 drinks in a week for females, 14 for males, and that's kind of been the kind of standard. If you're doing more than that regularly, or more than 6 on one occasion, things like that.
Clinically, that's what I would call a problem.
Yes, yeah, exactly. And that's still kind of the screening tool that we use, right? So looking at that and other parts of that, like, does someone else say that you might have a problem, or do you feel like you have to hide your drinking? And so things like that, these are tools we use to kind of screen out whether it might be a problem or not, because what is a problem as a provider to kind of point out to my patient, and it's not to point a finger at someone, it literally is to come from a place of, well, as your provider, I want you to have health, and that's my goal, is to just educate and to identify areas where you could tune it up, or maybe stay healthier.
Yeah. You can send them to me. I'll tell them that's an addiction. We need to get you in a meeting right now.
Yeah.
Yeah. But no, I appreciate that too, because I joke about that, but the reality is, and I had heard you share this on this perspective as well, of like, whether you believe it to be an addictive problem or not, it's really good to stay within the recommended health window for your life, for your overall life. And if you haven't gotten it by now, that's why we have these discussions week in, week out. How can we help make your life better? And I hope you heard some of this tonight on this perspective, and can just kind of look for yourself. Am I drinking too much? Is this good for me? Or do I need to cut back and have a serious discussion with my medical provider about it?
And we see so many things with alcohol, even a moderate drinking, right? Sleep apnea is one that's huge, like alcohol in general, sedatives and, opiates, the things that we were talking about earlier, they depress your respiratory. They have effects on the sleep apnea. And, when you have sleep apnea, which is an obstruction, possibly, there are other causes as well to having sleep apnea. You're not breathing in the night. You have apneic episodes, so you're not oxygenating. You're not. Your cardiovasculature is on increased stress. Under increased stress, when that happens, the intrathoracic pressure increases, and so your risks for heart attack, stroke, all these things go up. Well, one of the main recommendations from pulmonologists is stop drinking, watch your alcohol intake as part of that, as well as like your overweight or extra weight on your abdomen. Is those things are directly correlated, but that's one of the biggest ones is alcohol. So
yeah. So get moving, exercise, stop drinking.
Yeah, liver too. I mean, we see a lot of liver disease, even mild, just because of alcohol use.
Yeah.
Maybe not even high use, but moderate use.
Yeah. Well, and then you start talking about any other substances that their body is processing and trying to push out of the system, and your liver and kidney are going to be in some real danger.
Yeah, and alcohol breaks down into sugar. And, when I'm treating my diabetics, now typically they're not actively using when they're in our program. Our program has a 0 tolerance for alcohol, but we'll see veterans come in who have been heavily drinking and their blood sugars are sky high and it's not well controlled. And so their alcohol use and not, taking their medicine, controlling their diet, doing all the things that diabetics need to do in order to maintain their health and control their disease, they're not doing. And so typically when they come in, if they can do their diet and take their medicine, which are things that we try to encourage, their A1Cs, which is our measurement tool for diabetes, it improves drastically when they're not drinking.
Yeah.
So.
Yeah. I would imagine all the things you don't, it's like you wouldn't, if you're not privy to this stuff, you probably wouldn't stop and think alcohol breaks down into sugar and that's bad.
Yeah.
It's bad for your health.
Yeah.
I probably shouldn't have the cheesecake, but I'm going to do it. And but just all the things you gotta think about, keeping your sugar intakes down and alcohol, cutting that out. It's going to help you with your health a whole lot. And also, just as we probably are going to venture into other conversations, I think it's important here to note that if you're listening to this and you're kind of thinking like, hey, maybe I do have a problem, you will be very well supported by a wide range of professionals, and none of us are here to judge. All right, we're all just humans, and the support's out there for you, but you got to understand some of these things, and you got to be willing to do something about it. If you could do those two things, we'll meet you the rest of the way.
And you bring up a good point. Like any mental health professional, medical professional, it's not a one-size-fits-all. My goal as a provider is to meet you where you are. It's a shared decision making. I'm not here to tell you you shouldn't do this and you should do that and you need to take this medication and you don't need to do this. My goal is to listen to my patient and develop a rapport, meet them where they are, which is, are you taking this medication? If not, let's talk about it. Are you having side effects? Whatever that may be, I'm not here to say, well, you need to take it. You have to. if you don't want to take medication and you want to try other things, let's talk about it. Let's have an open dialogue. I love educating my patients, and I like having these discussions where I say, hey, you don't want to do this, you don't want that medication. Well, how can I help you achieve what I would consider a healthy blood pressure or whatever that may be? And so we are dialoguing about that. And I mean, I'm pretty laid back in general. I have things that I want to achieve for you, like blood pressure or like whatever, and I'm going to kind of, keep educating, because if you don't know, you can't change it. And then it is on you to kind of, not only be honest with me, but to do the things or to not do the things, and we discuss that as well. But if you don't like your provider, if they've made you feel some kind of way, go find another one. You're not gonna get the perfect provider that matches you unless you kind of shop around, because there are going to be people you feel more comfortable with, or that take the time, or whatever that looks like. But
yeah, well, it reminds me of what your colleague from the VA said last week of just and her and her husband were just sharing. It's like in any profession, there's the good ones and the bad ones. And my experience too has been coordinating, and I've shared this with you, working with nurse practitioners. I've always had a lot more luck with my clients and some of my more complex clients where it's comorbid substance use and bipolar disorders, and I do a lot of work in that realm, coordinating with nurse practitioners as opposed to even psychiatrists sometimes, who have a little bit, like you were touching on earlier, maybe more of a range of things they can prescribe, but the nurse practitioners have always just taken the time. They've taken the time, and my clients always appreciate it. And especially with like bipolar diagnoses, where it's like the biggest hurdle in the beginning is like, I don't have to take my meds. It's like, wait. Let's all get in this office and talk about why it's so important. But I hear that from what you're sharing, just like taking the time, listening to what they have to share. And I think a lot of people come into support, and this is what I've seen over the years, maybe you've heard of it too, is like, well, I'm going to be able to talk through all my stuff with the therapist, not the medical team. And it's like, well, maybe you're talking to the wrong medical team,
And I will say, I'm biased. I'm a nurse practitioner, obviously. Many of my own providers as a patient have been nurse practitioners. I feel like, and I'm not downplaying any other profession, I feel like we really have we take the time to really kind of have that extra connection, and we come at it with kind of this holistic approach where we're looking at the whole patient, and it's not, medication is indicated in many cases, but there's so many other parts to your health than just medications, whether that's, I'll tell my patients, you will need to go outside for 30 minutes every day, and I'll write it down and hand it on a piece of paper so that they have that, or whatever that may be. But nurse practitioners, and I'll kind of share a little information, because I still get asked this question, and that's, well, you're just a nurse, or are you a nurse? Or, there's a confusion about our role. We're master's and doctorate level prepared advanced practice nurses. So nursing has many scopes within there and many different access points. So there's associate level nurses, there's bachelor's level nurses, there's master's prepared nurses. These are all just registered nurses. The difference then with advanced practice is that we are board certified through a certifying body, which is nationwide, to diagnose, prescribe, order labs, interpret labs, order diagnostic testing, interpret those testing, same as a physician's assistant or a physician. We're not physicians because we don't have the same medical school model going through the same education and licensure, but it's an adjunct to that kind of care that you're getting. So whether you're seeing the physician or whether you're seeing the nurse practitioner or the physician assistant, you're going to get the same access to services for the most part.
Yeah.
Some of the caveats would be like those controlled substance medications.
Right.
Often you want or need some other controlled medication like for ADHD or something. You can see the nurse practitioner, but ultimately the physician's going to be prescribing those substances under their license. But you can see the nurse practitioner for all of the monitoring, the tracking, that kind of thing.
Yeah, your guys' model too of just your treatment team mirrors a hospital setting I worked at years ago, where you have the psychiatrist and there's a nurse practitioner. Nurse practitioner is doing a lot of the family practice work, and psychiatrist is kind of coming in for some of the really specialized stuff, but has a very full practice of his own, making sure things are kind of like medically directed, if you will. And it sounds like you guys have a similar structure there, but probably also with a wide range of professionals at the VA as well, like case managers and all that kind of stuff.
Nurse practitioners fill a lot of different roles, and I kind of touched on psychiatric nurse practitioners, where they are specifically trained with lots of clinical hours and experience in specifically psychiatric conditions, so treating all of those at a really fine-tuned level. I have experience in mental health. I can write your antidepressants. I can start you on antidepressants, or, some of the different sleep medications or different things like that, anxiety. But if you start getting, as a family nurse practitioner, if you start getting really complex, you're needing multiple medications, multiple antidepressants, and you're not getting your care managed, I will refer out to a psychiatrist or psychiatric nurse practitioner who's going to have more of that complex training to deal with the specialized portions of that. Now, once you get stabilized on that and you come back to me as a family nurse practitioner, I'll renew what you need. But as far as titrating and fine-tuning that, as a family nurse practitioner, I'm going to collaborate with someone who's got a lot more expertise. And we have so many disciplines in my field with nurse practitioners. So you have pediatric nurse practitioners that are going to focus on the pediatric population. We have emergency medicine and acute care, so they're working in the hospitals, going around to the ICUs and the sick patients. So you have so many different kind of access points into having a nurse practitioner do care. But I'd say if you were scared or if you weren't sure what the roles were, you can go to the internet and go to our certifying bodies and look that up. But you're going to get excellent care from a nurse practitioner.
Well, I just feel like as you were describing it, I was sitting here thinking like this is probably helpful for anybody watching the videos who might want to be within that structure of nursing. You gave a good breakdown of the different levels, and any one of them you're needed, and but there's quite a ladder you could climb if you wanted to, and I thought you gave a wonderful breakdown of that.
Yeah.
I also like that you mentioned this is where some of the things you were just sharing really work for me as I work with 12-steppers and those who struggle with substances and their family members, and the care needs to be holistic.
Yeah.
We need the medical care, the family practice. We need the psychiatric care. We need the mental health care. We need to get outside and touch some grass, right? You need some peer support. And without these things, we just know in the research the brain isn't healing effectively. Relapses are much more likely to be enacted in the realm of substance use, and that's before you ever get to comorbid discussions of like traumas and mental health. But I really like that you highlight that holistic approach, and I think maybe just with having a bunch of mental health professionals who've come on this show, maybe you can talk a little bit about what your experience as a nurse practitioner, because I know what mine has been, but what yours has been, collaborating with therapists and different mental health professionals, because a lot of them tune in, and I think they would also appreciate just hearing your perspective on it too.
Yeah, this is my first role being where I am now, because I've worked urgent care, family practice, a variety of spaces where I didn't collaborate immediately in my day-to-day. I just didn't need to. We functioned as a clinic, and you come in and you go out But in this specific role with the homeless population, and there are many places I think that function this way, specifically in recovery, mental health, et cetera, where we have a psychologist on our team, we have a psychiatrist on our team, we have multiple social workers, we have other therapists as well. It's a pharmacists, a peer support, like you've mentioned, with nursing collaboration as well. So you really have this kind of interdisciplinary approach, and what each person brings to the team is different and it's valuable. My medical perspective when we're looking at a patient may be different than what the social worker sees as their needs or what the psychologist sees as their needs, and we're able to collaborate together kind of holistically to get that patient maybe what they need, or look at it from different angles. Whereas I might not see the resources we have in this area, someone else might be able to bring that in. So you really get a good encompassing care. Yeah.
Who's the least valuable opinion on your team? I'm kidding. You don't have to answer that. I was just going to see if I catch
everyone
you
is very valuable. Yeah.
They're watching right now. Actually, Jackie. I hope I didn't get anyone's
No,
name
there's no
specifically.
Jackies.
Okay, cool. Jackie was a safe choice.
Okay. Like Karen.
Yeah, Karen.
We don't have a Karen either, so that's good.
Yeah, that it is nice, having been on interdisciplinary teams. And when we talk about that, do you want to define just real quick what an interdisciplinary
You
team
go
is?
ahead. Or I can. It doesn't matter.
Yeah, I mean, you've been touching on it the whole time.
It's your a discipline would be the pharmacist is one discipline of a profession. You have your physicians, that's one discipline. You have your social workers that's a discipline in and of its own, that because they'll see something different than maybe what a family marriage therapist, your role is differently. You all have what you bring to the table from your unique perspectives allows you to care for the patient in a very collaborative way. Yeah.
So that's much more. I was just gonna say we all do different stuff.
Yeah.
Stuff.
Uh-huh.
Yeah. So what kind of got you into doing all this, being in family practice and climbing up the ladder of becoming a nurse practitioner?
I've always been drawn to medicine in general. I totally geek out on looking in microscopes and looking at the human anatomy and things like that. And I liked taking care of people. I liked helping people as a kid. And I, even as a youth, had a nurse practitioner that was a provider in our clinic that we went to as a family. And I thought, well, I really connected with her. I just thought she did a great job and took care of me in a way that I felt was meaningful. And I thought, well, I want to do that. And so I got my bachelor's in nursing. I worked as a nurse for several years while I got my master's in nursing. And then I've been doing that for 11 years now and in advanced practice. And the thing about nursing is everyone says it, but it really is such a broad field, and you can do research, you can do education, you could work in schools, you could work in the hospital, you could work in your community, you could consult on insurance claims. I mean, there's just so many things you can do in this field that if you don't like working directly in the hospital, or shift work doesn't work for you, or whatever that looks like, you have so many different things you could dabble in and get experience with. Flight nursing, you can travel nurse. I mean, it's pretty adventurous.
Yeah, it's a very popular profession. I can see why. Oftentimes, and I know you and I've joked about this before, but you get to wear scrubs every day. That's got to be nice.
I love it. Yeah.
You wear a nice jacket too, though, as a nurse practitioner, don't you?
I do have a white lab coat if I feel so.
That's how I always
professional.
found the nurse practitioner.
Yeah.
And I might say where's the advanced practice?
Yeah.
Not that I wouldn't lean on nurses too, right? That are just wearing the scrubs, right? I don't mean anything by that, but I would always look for the nice jackets.
There you go. Yeah.
Yeah.
We have those.
I have maybe a little bit more of a charged question, and we don't have to have any specific answer on this either way between the two of us. But as a medical professional, someone comes into you, they're smoking marijuana. What's your take on it?
You know, I'm going to encourage them to not. And, you know, we could break it down into smoking in general is not healthy, right? So inhaling something into your lungs that's a foreign substance, it's not good for your lung tissue. Marijuana specifically has, you know, the effects of the hallucinogen and those
It'll get
different,
you high.
yeah, those different properties as well. And so, you know, it's not going to, depending on how you use it, I think you need to look at why you're doing that. Why are you utilizing a substance in general to change how you feel?
Yeah.
And just from the medical perspective, I don't recommend it for your health. But in the mental health side is, what are you wanting? What are you achieving with that?
Yeah, and oftentimes, you know, getting past the barriers of denial to see that substance too is causing you a lot of conflict and distress in your life. And I don't know if you guys see this a lot at the VA too. I imagine you do, but marijuana is a tough one. There's just such a narrative around, oh, this is great for me. It's like, look, I'm not sitting here saying this is going to kill you today.
Yeah.
I'm just sitting here saying, like, you know, your interpersonal skills aren't that great. Your reprocessing abilities aren't that great. You're slow to the uptake. Like, that doesn't sound great, you know, and you're going to have lung problems. I mean, sure, then you get into the discussions with every pothead who's going to watch this on TikTok to say, like, oh, well, I eat it. All right. It's like, okay, well, don't fucking do that. Stop it.
You know, we actually do get once in a blue moon. A lot of people utilize marijuana in addition to. So their main thing is alcohol or their main thing is crack cocaine or whatever, but they still smoke marijuana. We do get occasionally someone who's just such a heavy cannabis user that they are not functional. Their use is interfering with their life, and that's when you kind of look at whether it's an addiction or not, right? Like, where is this substance that you're using regularly affecting the other parts of your life? Whether that's finances, you know, in the homeless population, a lot of people are homeless because they are utilizing, and their money's going towards substances.
Yeah.
Right? Or they're not working because they lack motivation, or their hygiene is poor, or their nutrition, these other things where they can't achieve a quality of life that would be meaningful.
Yeah.
Yeah.
Yeah, and this is where you'll hear kind of the most common denial with any substance, but the version of this, marijuana is like the unique one where you'll hear over and over, well, it's not addictive. And I like to be really clear with my clients on this one too. Your addictive process has absolutely nothing to do with the substance. Nothing. It's the behavioral process underneath, the isms, right? That, you know, you and I know working with these individuals. It's, you know, and I can attest to that in my own behaviors in my own life and things that I've cleaned up. It's like it had nothing to do with whatever the specific engagement you were in with a substance or a behavior. It had everything to do with the way you were behaving.
Yeah.
All right. And, you know, that one's it's a constant one to have to break down in the populations the way it exists today, because marijuana is just so pervasive and very touchy. But
Well, and I think you have to also look at, from a safety standpoint, when you're doing something that's altering your mind, right? What other choices are you making that could potentially be harmful to you? So alcohol or marijuana, some of these things, they dull your inhibitions in a way that now maybe you're going to engage in other behaviors that aren't good for you as well. So if it's drinking, well, maybe you're going to then pick up another substance that, because you've let your guard down or you've dulled that sense of, I don't know, being able to think through something clearly. You've altered your mind in that way. Yeah. And I think marijuana and alcohol both do that to whoever's using it.
Yeah, pretty clearly. I mean, I remember when I used to work at the Amen clinics and we would look at the blood flow to the brain. It's like the moment you ingest this substance, and alcohol is pretty fast acting too. The blood flow to your prefrontal cortex where you're making all your decisions, gone.
Yeah.
You know, and you're not getting it back anytime soon either. So, you know, I think that's a common misconception with brain health. It's like, well, my brain will be fine tomorrow. It's like, if you're even thinking about your brain at all, it's like, no, your brain's going to be fine in a matter of months. And if you're severely using it, you're looking at 12 to 36 months if you stop using it. And that's marijuana, methamphetamines, opiates, alcohol, whatever it is. And so it's just tricky to get in there because people don't want to change it, you know, and that's unfortunate.
Well, and you bring up a good point with the brain, because alcohol and these substances change the chemistry of your brain. And so having that clean time, fully clean, no substances, your brain can heal, and it does heal from the effects of that, not only on a chemical level and and I'll just point out something else too. Alcohol, marijuana, these things, they're depressants. And so when you have something like depression already, prone to it, or you deal with it, you battle with that, it's going to further exacerbate that condition because you're dulling, you're affecting the chemical levels, the hormone levels, the dopamine, the different chemicals in your brain. And when you get the clean time, you'll notice the mood lifts and those kind of things. But we also see, you know, dementia and things like that, cognitive problems when people are using. And when you stop and you get that good long clean time, things will improve. Your brain can heal, but you got to give it a chance.
Yeah, that's the best way to be. You got to give yourself a chance. So as I'm listening to you as well tonight, it's like the stacking nature as well of like where care needs to be holistic, the consequences within your body are total. Right. So it's like, you know, you're not taking care of yourself behaviorally or taking accountability for your behaviors, which then causes you to fall behind on taking care of your medical health or your physical health. And now all of a sudden you're complicating that because maybe, you know, you've contracted some kind of issue because you're engaging in some kind of substance, and now that's getting out of control. And now you feel depressed because it's just the holistic care is needed on the other side of it, because your body is going to be going through this total process that you have to give it a fighting chance to recover, and it's going to need some time.
Yeah, and I'll touch on briefly just because I love to educate. When you're using substances and you're not making sound choices, you're going to expose yourself to more risky behaviors, whether that's injecting and exposures to HIV and different blood-borne pathogens, or engaging in risky sexual activities that you can contract, HIV, syphilis, these kind of things, or unintended pregnancies, or whatever that may be, that you're not able to think through those decisions clearly, and you're not making sound choices. So it's just something to be mindful of, I think, and I'll just kind of plug, you know, seeing your provider routinely is helpful.
Yeah.
There's so many community resources as well. If you are unable to afford medical care, there's so many places that provide medical care for free of charge or low cost or sliding scale, these different places. So they're out there. But you got to find them.
Yeah, you just got to start looking.
And I'll speak a little too, just because I've had personal experience in this. But, you know, if it's a choice between, affording this medication, that could be brand name, having these discussions with your provider and not being too afraid to say, like, I can't afford this. Like, is there a cheaper alternative? Or do you take cash pay because my insurance deductibles are really high? Like, people are willing to work with you, and you can talk to the office manager. You can negotiate your bills even if they're really high. But it does just take some calls and some knowledge that is a possibility. And I hate that it is, because it's such a hoop to jump through to get access to medical care. But you can do it if you kind of educate yourself and advocate for yourself.
Yeah, I think that's important to hear from a medical professional, that you can ask these questions and that people will help you figure it out.
Yeah.
I could talk to you all night long, Madeline, and in fact, I'm sure I probably will. But I have a question for you before we get off the live YouTube conversation here that I ask every new guest, and that is, if we were going to build a mental health amusement park and you get to build a ride at that mental health amusement park, what would it be and what would you call it?
I've been preparing for this question. So my favorite games or the rides at the amusement parks are those like dark rides where you shoot things and you're like spinning and it comes up and you have a little gun. And it would be like different questions or medical screening things, and you have to like get it right, or go through the life's journey of like getting your vaccinations, and you're like shooting those to complete your health tasks. Like, it's very much like a check mark game, because I love doing that. When you turn 50, you're getting the colonoscopy and you're shooting that one down or whatever, because these are things a family nurse practitioner does, is making sure you're meeting all these milestones through your health to screen for risk and keep you healthy and living as long as you can.
And what would you call it?
Cradle to grave of health and wellness. I don't know.
Right.
It's a really boring name, but
We'll take it.
I didn't think that through. The name
No, that was a great answer. Well, I appreciate you coming on and being our last show of the year.
Woo!
Yeah, thank you.
2025 is coming up.
Ladies and gentlemen, Madeline Taylor, family nurse practitioner. We break the cycle here starting in the new year on the 10th at 7 p.m. Central Standard Time. We'll be back to our show. We're taking the next 2 weeks off. And based on this conversation, just remember, kids, drugs are bad. Stay off of them and tune in here in 2 weeks. We love you.